Colonic serrated lesion or adenoma presented by Maha Emad, lecturer of pathology, Cairo University. It's a serrated neoplastic precursor lesion of colorectal cancer, and it is linked to serrated polyposis syndrome, which includes one of the following criteria. An essential feature is that if it is present in any patient, this patient should undergo increased colonoscopy surveillance, as it may develop traditional cytologic dysplasia and progress to colorectal carcinoma. It accounts for approximately 10% of all colorectal polyps and 20% of all serrated polyps. Its prevalence increases slightly with age, and it's more common in women. And the current preferred WHO designation is sessile serrated lesion instead of sessile serrated adenoma. It's more often found in the proximal colon, and it is usually an incidental finding on colonoscopy unless it progresses to malignancy. And like other carcinoma of the colorectum, it is usually associated with a high fat and meat diet, smoking, alcohol, and a high body mass index. Approximately 15% of patients with these lesions will develop adenomatous polyp, dysplastic adenomatous polyps, or colorectal carcinoma, and any patient with lesion more than 10 mm in size has a higher risk of developing colorectal carcinoma. Polypectomy or endoscopic mucosal resection is usually the treatment of choice, and it's highly recommended to completely remove all serrated lesions proximal to the sigmoid colon and all serrated lesions more than 5 mm in the rectosigmoid colon. Also, any lesion more than 1 cm in size or with high-grade dysplasia should be managed clinically like a high-risk adenoma. They usually harbor BRAF mutation, leading to microsatellite instability through MLH1 hypermethylation. They are negative for KRAS mutation, unlike other colorectal carcinoma. This lesion may be flat or sessile, with indistinct edges and color similar to the adjacent normal mucosa, as shown in figure A and B. Also, by using narrow band imaging, they typically have a weak or normal vascular pattern, as shown in figure C. And according to its name, sawtooth serrations is a characteristic histological feature. Also, among the most characteristic histological feature is basal crypt dilatation with mucus secretion, where the lateral spread of the crypt is commonly described as boot-shaped or anchor-shaped crypts. Conventional dysplasia may also present with retained MLH1 staining, demonstrating dysplastic glands which have nuclear elongation, enlargement, and stratification while maintaining a serrated morphology as shown in the figure. Non-conventional forms of dysplasia may have also been described, including different types with often loss of MLH1 staining, as shown in this figure, where the staining is lost in the dysplastic glands. Differential diagnosis is usually between hyperplastic polyp and traditional serrated adenoma. In figure A, the sessile serrated adenoma or lesion, the crypts show basal dilatation and serration, which is more prominent in the basal part than in the upper part in a crescendo fashion, while the condition is reversed in hyperplastic polyp, shown in figure B, where the epithelial serration and dilatation are more prominent in the upper part than in the basal part in a decrescendo fashion. A take-home message: sessile serrated lesions are more frequent in elderly females and in the right colon. They are premalignant lesions which are linked to serrated pathway of colorectal carcinoma, which makes up about 15% of all colorectal cancers. It can be detected, diagnosed, and removed, and eventually it can be prevented. Thank you.